So what effect does an islet transplant have on the secondary complications of diabetes? We know that from pancreas transplantation, a successful whole pancreas transplant, although that's a huge operation for a patient, can actually turn around many of the complications. So coronary artery disease, poor heart function, changes in the artery walls, kidney function, all of these things can be changed and reversed by a successful pancreas transplant, and an islet transplant can do exactly the same thing. And we know that if we give too much insulin to a patient, well, they get hypos, and we know that if we don't give enough insulin to a patient, their A1C and their control is poor, and they get rapid complications such as blindness. And so the islet transplant can very effectively get this balance far, far better than any injected insulin therapy or insulin pump. Here's some pictures of a patient who's had a successful pancreas transplant, in this case published in the New England Journal of Medicine, where there's actually a reversal of kidney function damage by a successful pancreas transplant. And we know now from early studies from several sites that a successful islet transplant will in fact do exactly the same thing. In fact, I should tell you there's more than 80 trials going forward in clinical islet transplantation at the present time, many of them happening at my own centre in Edmonton. We had a lot of enthusiasm for islet transplant initially, but this shows that in our previous experience, only 15% of patients could stay free from insulin at 5 years, although many patients, 73% of patients, continued to have good islet function, sufficient to prevent complications and very sufficient to prevent the lows after transplant. So we took this problem back to the laboratory and carried out further refinements in our Edmonton protocol treatment. And we found that by the addition of what's called a T depletion therapy, in our case it's called alemtuzumab, an antibody that we give to the patient once before the transplant, we can prevent this from happening. This is the recurrence of autoimmunity and rejection of islets after transplant. So this simple treatment, one injection of that thing called alemtuzumab, together with very standard anti-rejection treatments and a simple approach in transplant, can transform our outcomes. So here is our 5-year outcomes now with this new alemtuzumab approach, showing that 93% of patients continue to have good islet function over time, and many of these patients remain free of insulin. This is the A1C levels in our patients before transplant at around 9%, corrected to completely normal below that 6.5% line there after transplant, indicating that these islet transplants will stabilize and prevent complications from diabetes over time. You cannot achieve this level of control even with intensive insulin and even with insulin pumps. These are the scores for our patients, the risk of hypos before and after transplant. The blue line on the left, the box is high, it's down to absolute 0 after transplant and remains so at 5 years. The same thing with our hypo score. So these have dramatic effect on patients, as Joan will tell you here.
I feel my control now is the best it's ever been in 20 years.
So this is the insulin independence rates in our patients with our new protocol. You can see that 77% of patients remain insulin free at 5 years with this new approach compared to 15% before. So this is a dramatic improvement, and we're really, really pleased with our outcomes. So our gap is closing. Certainly our results now are very similar to the big invasive pancreas transplant operation. So simple injection once or twice inside the liver can achieve the same as a major operation. So where are we going from here? We want to take our treatment today, which is getting better and better, and we want this to be a cure for patients of tomorrow. So we have many challenges. This is sort of taking the problem back to the research lab. We know that when we put the islets into the patient, not all of them survive. It's like a hole in a leaky bucket. So we don't have enough cells surviving. We want to find ways to prevent rejection, thrombosis, and prevent the recurrence of autoimmunity after transplantation, and also to help the islets grow over time. So it's a complex process. So we're addressing this and tackling this problem in many different ways. So we are very excited about the opportunity to control inflammation, to facilitate what's called immunological tolerance, so the patients don't need so much of the anti-rejection drugs, and also we can prevent and reduce the risk of immune activation after the transplant. How are we doing this? We're giving anti-inflammatory strategies to patients. This is a treatment that we gave to mice actually initially. It's called the combination of anakinra and etanercept, 2 antibodies that are used actually in rheumatoid arthritis to prevent inflammation. We found that when we gave these 2 antibodies together in mice, given human islets, that we could just use a very small amounts of islets to completely cure diabetes in mice. So we've taken that now to the clinic. We're testing the combination of anakinra and etanercept in our patients, and so far we're finding very encouraging and safe results. Now, caspase inhibitors. Caspase inhibitors stop cells from dying. When we put our islets into patients, we know that a proportion of those cells, quite a large proportion, are injured and don't always survive. So by giving a simple drug for a couple of weeks after the islet transplant, we can switch off cell death and we can improve the survival of our islets. So here's a study we did, and we've done several of these studies in mice given human islets, and we find we only need 1/10 of the mass of human islets when we give these drugs to a mouse compared to what we would normally give. So these are very sparing of islets. 1/10 of the islet mass needed to cure diabetes is quite an achievement. We repeated these studies with several different drugs. We repeated these studies in a large animal pig model with receiving the marginal mass islets. And now we are ready to take this treatment to the clinic. We have a protocol that's moving forward now through Health Canada, has just undergoing the approval process through the ethics board, and we anticipate starting this very exciting clinical trial within the next few months. I think it really will make a big difference to patients. Our lab studies also suggest that this approach to stop cell death may facilitate tolerance induction in a proportion of the mice as well. So we hope that this might occur over time with patients too. So we're very excited about that approach. And I won't go too much into the details there, but we're very excited about it.